Welcome everyone to the Ontario Caregiver Organization's webinar series. These webinars bring together caregivers and subject matter experts to explore topics of interest to caregivers. We do this to support and engage chosen family, friends, neighbors, really anyone caring for someone else. My name is Katie Muirhead, and I'm going to be your moderator for tonight. We begin this gathering by acknowledging the Indigenous peoples of all the lands that we're on today. And while we meet in a virtual platform with people joining us from across the province, I'd like to take a moment to acknowledge the importance of the land which we each call home. The land that I'm standing on is the traditional territory of the Haudenosaunee and Anishinaabe peoples, many of whom continue to live and work here today. This territory is covered by the Upper Canada Treaties and is within the land protected by the Dish with One Spoon Wampum Agreement. Today, this gathering place is home to many First Nations, Métis, and Inuit peoples, and acknowledging this reminds us that our great standard of living is directly related to the resources and friendships of Indigenous peoples. As team members at OCO, we are learning about the lands from which we work and exploring how we can be meaningful allies and how we can support the recommendations from the Truth and Reconciliation Commission. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our understanding of local Indigenous peoples and their cultures. We invite you to take a moment to reflect on the land where you are. And if you're not familiar with that, we will be sharing an interactive map that tells you which traditional territory your city or town sits on. And you can find that at native-land.ca. Our webinar today is called PTSD and Unpaid Caregivers, Risks, Signs, and Support. Post-traumatic stress disorder, PTSD, can impact family caregivers facing chronic strain, as well as those exposed to life-threatening events. It's important to learn the signs of caregiver PTSD so you can take immediate action to prevent things from becoming worse. We're joined today by Dr. Patrick McGrath. Dr. McGrath is a clinical psychologist and Emeritus Professor of Psychiatry at Dalhousie University. He's also an adjunct professor at the University of Ottawa and founder and president of the 90-Second Health Letters. Today, he will cover the nature and symptoms of PTSD, how often it occurs in caregivers, and share some strategies to support caregivers going through this. Welcome, Dr. McGrath.
Thank you very much. It's very nice to be here tonight. I'm very privileged to join the Ontario Caregiver Organization. So we're going to talk tonight about PTSD and caregivers, the risk, the signs, and supports. So the first questions, this is the overview of what it is. We're going to talk about what is PTSD, the symptoms, PTSD in caregivers, some of the measurement tools that we use and the risk factors and the treatment, and then tips for managing PTSD as a caregiver. So PTSD is the recreation of a very traumatic event. And traumatic event means something that was a life-threatening event. So that's the technical definition used by the American Psychiatric Association and International Classification of Diseases. And what happens is that you begin to get recreating the traumatic event after it's occurred. You may avoid people, places, or activities that trigger these memories. All of this makes sense if something is very, very unpleasant that you may avoid wanting to trigger that. But it doesn't work very well. And you get a hypervigilance. That means you're always on guard. You're always ready for something to happen. The emotions of anger or sadness or fear may come on you without any notice, and it interferes with work, social, or family life. Now, caregivers are generally not wanting to admit when they have things that are interfering with their work, social, and family life. They figure, well, they just have a job to do and they want to go ahead and do it. And that becomes a bit of a problem because they don't take good enough care of themselves. So these are some of the signs and symptoms from the PCL-5. The PCL-5 is a very widely used scale to get a good idea whether somebody has PTSD. Now, the diagnosis of PTSD can only be made by a psychologist or a physician, and only after interviewing the client. And oftentimes what I do is I will interview a client, and I also will do a PCL5. In fact, I typically use the PCL5 as a tracking instrument. So these are the types of things so that, excuse me, so you may feel or act as if stressful experience is actually happening again, or you avoid external reminders of the stressful experience, or have strong negative beliefs about yourself, other people, or the world. Oftentimes there's a feeling of distance or being cut off from other people, irritable behavior, angry outbursts, or even acting aggressively. And then the hypervigilance and being super alert or watchful or on guard, feeling jumpy or easily startled, and having difficulty concentrating. So these are the type of symptoms and signs that are common in PTSD. So I should tell you how I got into PTSD research. I was working in a study with parents of children with neurodevelopmental disorders, and I had applied for several grants because we work always very well with family and with parents. We always have them on our research teams. And I got turned down on a grant, and Donna Thompson, who is a fantastic advocate for families, she said, well, why don't you do a PTSD study on us? And I said, well, what do you mean? We are doing some studies with your children. And she says, no. Caregivers get PTSD, Patrick. And I said, what? I didn't realize this. And she said, just think about our experience. And in this case, it was with children who have neurodevelopmental disorders, but it's true with caregivers that you will often have multiple situations where there is real threat of very serious harm to your caregiver, to yourselves as caregivers, or to the person that you're taking care of. As well, of course, caregivers are like the rest of us, and they may have been in accidents, or they may have been have been assaulted, or have been in an earthquake, or in a forest fire. And so all of these add up, and over time, many caregivers have PTSD. My own experience as a caregiver was when my wife died. She had ovarian cancer, and I cared for her for the last several months at home. It was a very difficult time. She declined and eventually died, but it was very rewarding. So I have some insight, but only limited insight as a caregiver. It was a very limited experience, but it was very, very, very meaningful to me. So trauma comes from the Greek, and it means a wound. And the definition is exposure to actual or threatened death or serious injury or sexual violence by directly experiencing something, by witnessing it, or even in the case of learning about the traumatic event of a close family member or close friend. It's not considered a trauma if you see something on television that isn't related, with somebody that isn't related to you, and experience repeated or extreme exposure to aversive details of the traumatic event. So in fact, therapists sometimes develop PTSD from discussing with their clients, but it's a risk, but it's not a serious problem if the therapist learns how to take care of themselves. People who have PTSD you've never left the traumatic scene. They're stuck in the event. The threat isn't over. So it may have happened 10 years ago or 15 years ago, but you get right back into that experience. You're in a survival mode. It's a basic fight or flight response. And the traumatic event is with a person with PTSD always, or threatening to be there all the time. The present, when you're in that, the present seems more like an illusion or a dream, and the PTSD seems what's real. And then again, there's often impairment of social work and family functioning. Complex PTSD is sometimes distinguished as being something that's from multiple trauma. And oftentimes people with this disorder have starts in childhood. They may be ongoing in terms of repeated violences or ongoing health crises. And of course, this is most typical of people who are caregivers with PTSD, although you can develop PTSD from a single event. So what are the risk factors? Being female is a risk factor. So women are more likely to develop PTSD than men. And that doesn't mean that men don't develop PTSD. It's just that if you're a woman, it's more likely. Lack of social support. So if you're isolated, and sometimes the role of caregiver makes one more isolated. So childhood adversity or trauma, and that is an important part of what happened to you in your childhood. Higher education seems to be a bit protective. If you have anxiety or depression, then that's a risk factor. The severity of the trauma is an important risk factor as well. And now, finally, genetics are important, but it's very complex. And although it's quite clear that there is a genetic component, it may vary where the genetic component arises in the genetic code may be different for different populations. And it's just not clear yet. There's clearly a genetic component, but there's no gene for PTSD. So life events, and this is from the life events checklist, things that are usually asked of people when we're screening for PTSD, and these are the types of things that are included. So you might have life-threatening illness, or very severe human suffering, or assault with a weapon, or physical assault, exposure to toxic substances, some sort of natural disaster. A very common one actually is other unwanted or uncomfortable sexual experience. So in a study that we've done with parents of kids with neurodevelopmental disabilities, we found that transportation accidents were the highest, and other unwanted or uncomfortable sexual experience or physical assault. So people with PTSD, the parents of kids with the neurodevelopmental disorders, this is the rate in the whole population, not just in those that had PTSD. So we developed a scale for this subpopulation of caregivers, and the largest one, the most common one, was experiencing a medical emergency of your child. But also things like witnessing serious self-harming behavior of your child was a quarter of the respondents in the whole survey, not just the people who had PTSD responded that. Witnessing a severe accident or injury, and things like being in the ICU, the NICU or the PICU, the neonatal intensive care unit, the intensive care unit, or the pediatric intensive care unit. That was another common trauma. Now, this is an example from an individual, and it's done in the form of a lifeline. And this is very commonly done with the one type of treatment called narrative exposure therapy. And so what we do is if you're doing it in the office, you lay out a rope and you put down stones and candles and flowers. Flowers are the happy events. Stones are clear trauma, and then candles are important events that were not clear traumas, but are important events. So you see that you may have many different things in terms of this one individual who had. So these are the types of ways that we collect the data, either by a scale, by interview, or by something like this, a lifeline. Now, I mentioned before that there is a very commonly a number of traumas that people have experienced. So once we see that in this group, we see that the number of traumas experienced as it goes up. This is one from our parents' measure and also from the general measure. And what you see is that as the number of traumas go up, the probability of having PTSD increases. So when somebody has had 32 general traumas or 18 of the traumas in the parents' measure, they're about 90% likely to have PTSD. So some people say that if you have enough trauma, everybody will have PTSD. So it's not a matter of weakness. It's not a matter of being particularly vulnerable. Although there are risk factors, it's the trauma that causes this. And so what happens is in this little cartoon, you may have you're carrying your lifetime trauma and other stressful events, and then a small trigger occurs, and that may trigger PTSD. And you may wonder to yourself, why all of a sudden I get the PTSD? Why all of a sudden I have these symptoms? But you've been carrying this for a long time. So what happens, this is an example of a little cartoon from a patient. And this patient had a situation where in the past there was a crisis with their child, and they get a lot of fear. Their heart pounding. In this case, it was somebody who had been phoned about their child having seizures at school. But then now, every time the phone rings, they get that whole experience is relived, and they may have the heart pounds, the physical symptoms, and the memories and the psychological symptoms. And this PTSD often causes a spread of fear and a spread of concern. So you may have, for example, let's say you have had a trauma where you were in a car accident, and it was a red car, and it was on Smith Street. Well, maybe afterwards, when you go down Smith Street, you get a very uneasy feeling, and you may begin to get, terrible feelings. If it was, and you may have a memory of that. You may even have a flashback of it. But it then, over time, maybe then, a couple of months later, you might be introduced to a John Smith, and all of a sudden, you tense up and you become hypervigilant because, John had nothing to do with the accident, except his name is the same name as the street that the accident occurred on. So it spreads. Now, in our sample of about 500 families, we saw that, and these are all caregivers of a specific population, we saw that about half are saying that they have excellent or very good physical health, and about 60%, almost 60%, had PTSD. The quality of life, again, was fair or poor most commonly, and there was significant problems with mental health. So this isn't a small percentage of caregivers. Now, it wasn't a completely representative sample, but it was a sample of people who were giving us information about caregiving. And what we see is that and this is backed up by other literature, that caregivers are at high risk for a lot of mental health problems, for anxiety, for depression, and for PTSD. So in some ways, I like to think of PTSD as a memory problem that causes psychological difficulties. So you get highly emotional memories. They're often fragmented, and not all the time are they completely remembered. They're actually stored in the brain in different areas of the brain in a different way than regular miserable memories. We all have regular miserable memories. We recall them. We're not happy about them, but it doesn't grab us. It doesn't control us. And in the brain mechanisms in PTSD have been worked on quite extensively, and it's a very complex, but in general, the amygdala is hyperactive and the medial prefrontal cortex is less active. And the memories trigger arousal, and then that web of fear that I was talking about spreads. Unfortunately, if not treated, PTSD tends to persevere. So people who think it'll just go away, oftentimes it won't. Some people, it does just go away over time, but oftentimes it doesn't. And the example of the veteran coming back from the war and not wanting to talk about anything, but having effects of the PTSD is well represented in movies and such. Caregivers aren't usually represented in movies as having PTSD, but it's true. So the fear persists, we think, because memories and situations are avoided. It feels better in the short run when we avoid these very terrible memories, but it's not going to go away just because we avoid it. And when events occur, then the person feels better when they avoid it, when they get rid of it quickly, but again, it comes back. And the symptoms isolate people, and the sleep disturbance often occurs, and that always has a huge effect. And with caregivers, sleep disturbance is very common because of the caregiving itself. And so these things come together. So there are, fortunately, good treatments for PTSD. There are good medical treatments, and there are even better psychosocial treatments. And there's been dozens and dozens of studies done on these treatments. The antidepressants, the SSRIs, are effective in treating PTSD. And that's usually the first line of defense that a family doctor will use. Psychotherapy itself is moderately effective. So talking about your problems and difficulties in a more unstructured way with a therapist is often effective. But even more effective are the trauma-based therapies. And these types of therapies are ones that in some ways recreate the situation, change the memories. That's the key. They change the memories. One of them, the best known one and the one that has most research on it, is called prolonged exposure. It was developed mostly for veterans in the United States, but it's been used in all sorts of populations. And I've been trained on that. And what we do in that is that we choose an index memory, the worst memory, the one that's interfering the most. And we walk through it as if you're directing a movie about it. And you talk about your internal state, the external situation, and you walk through it, and you do that over and over and over again. Narrative exposure therapy is a little bit different, and it doesn't choose an index, but it goes through different trauma over time. And sometimes we go through all of the traumas if there's a limited number, but sometimes you just choose some of the worst ones. And again, walking through the trauma, relating one's internal state, one's emotions, and the events that were occurring. The most recent one is written exposure therapy, and that is shorter therapy, seems to be as effective, but there's not quite as much research on it. And again, it chooses an index trauma, a single trauma, the worst one, and goes through it. Now, when people say, well, doctor, I have lots of traumatic memories. And I say, well, yeah, it appears that once the brain learns to refile those memories into the normal miserable experiences rather than trauma experiences, it tends to generalize. Not always, but it tends to generalize. And then EMDR, which is a therapy that I don't do, but I've read about it a lot, and it's when a person focuses on a specific thing, like a finger moving of the therapist, and also remembers the memories. And then finally, cognitive reprocessing therapy is a little bit different, often done in groups actually, And it is, again, going over specific situations and how to manage them. But it is, again, a trauma-based therapy. So written exposure therapy is the one I use most commonly right now. It's as you can see, the book on it was written in only 2019. You have 5 exposure sessions. Usually it takes at least 7 sessions. It's less challenging often for the patient or client, and it seems to be as effective, and that means it's less costly. So, but there's a lot of things that people can do without treatment. I would encourage people, though, to get treatment, but it's not easy. It's not easy to get treatment. We don't have a sufficient supply of therapists, and oftentimes the ones that are doing work are in private practice, and that's expensive. But some of the tips for managing PTSD are engaging with friends and family, overcoming that isolation that is so common both in PTSD, but also very common because of the demands of caregiving. Relaxation, meditation, yoga, deep breathing, keeping active. That seems to be helpful too. Walking, swimming, doesn't matter what. It's just being a little bit more active every day. And improving sleep, often through making sure that you try and get a good place to sleep, and it's quiet, and going to bed at the same time, and no screens before you go to bed. And of course, reducing alcohol and recreational drug use. So alcohol and cannabis in particular, the most widely used, they tend to make the symptoms better in the short run. Immediately you feel a little bit better after you've had that glass of wine. But in the long run, it makes it much worse. So if you can gradually reduce your avoidance, if you notice that, oh, I'm avoiding going on Smith Road, well, then maybe you just gradually try and go back to Smith Road if that's where you had your accident. Or if you're avoiding thinking about a situation in your caregiving experience where the person that you're taking care of had a serious crisis, well, it's not a bad idea to go gradually, bit by bit, remember that. Except that at times you're going to have reliving of the trauma. Journaling is really, really helpful. Writing things down about the events, describing your events, your thoughts, your feelings, reminding yourself that that's the past. This flashback is the past. I'm now here in Mississauga in September 2022. That happened, yes, 3 years ago. Keeping calm, breathing deeply and slowly, and reminding that you can handle it. I mean, most of these things people have handled dozens of times before. Wanted to tell you about something we're doing in conjunction with the Ontario Caregivers organization, and that's 90-second caregiver. And you may want to sign up for it. That's the funny little squiggle box that you can take a picture of with your camera, and then you can get it. You can go right to the website. And we're trying to support caregivers by giving specific tips and ideas for caregiving. And it's evidence-based information. And each weekly newsletter gives a tip and a self-assessment and a personal story from a caregiver. And you can sign up for free. I want to thank you very much for your attention. I really enjoy talking about this topic, and I'm very privileged to be collaborating with the Ontario Caregiver organization. Thank you.
Wow, thank you so much, Dr. McGrath, for sharing your expertise with the audience today. We do have some time for questions. If folks have questions, we've seen a few roll in already through the chat box. Please put some more in there, and we're going to take some time to answer your questions now. Dr. McGrath, if you want to go ahead and stop sharing your screen so they can see both of us clearly while we're doing our Q&A. Wonderful, thank you. So we'll start from the beginning, and then our backstage crew will be feeding me questions throughout this period. So one of the first questions that came through was around sort of severity of trauma. So would duration, so if you've been caregiving for 30 years, so would duration or intensity or any of that impact that diagnosis of PTSD in any way?
Yes, it is likely to, especially if there were a number of discrete events. And so, for example, when, if there was a medical crisis, and probably caregiving over 30 years with somebody with a chronic condition, there have been times when there really was a very serious medical crisis, and so that the duration of the caregiving is important. The thing about severity of events is a lot. Some of that is objective, but some of it is subjective. If I'm, for example, when my daughter was an infant, she had seizures induced by fever. Now, I knew that because I'm a health professional and I dealt with kids with seizures, I knew that it wasn't necessarily, a life-threatening event. But I still got my emotions up, and I didn't develop PTSD. But so it depends on your subjective point of view as well. And oftentimes, if you don't know what's happening, it's very, very scary, even though a doctor may say, oh, well, that's okay, it was just this or that.
Yeah, no, that makes a lot of sense. We can sometimes take our own personal or professional experiences into account as well, which may or may not. My experience is different than yours from a caregiving perspective.
Absolutely. And we have to really respect, if I think that the person I'm taking care of is going to die, then that's how I experience it. And somebody with a neurologist will say, oh yeah, that's just a grand mal seizure, nothing to be worried about.
Yeah, we see it every day.
yeah, well, they see it every day, but the caregiver didn't.
Absolutely.
And
absolutely.
the other thing is the important thing is that when you're doing this under the duress of lack of sleep or general anxiety because of the well-being of that, or being cut off from your social support because you're spending all your time caregiving, that is an increased risk for PTSD. Now, of course, PTSD itself is going to make other symptoms worse. So oftentimes people with PTSD come to my clinic and they say, well, they have they come with anxiety or depression. And then when I do a history, I found out, oh yeah, well, it's PTSD there too. And you can't tell which is which, which came first, which is chicken, which is egg. But usually what I would do would be encourage the treatment of the PTSD, because sometimes much of the depression, much of the anxiety disappears when the PTSD is successfully treated. So it's complex. And although I think it's very important to get treatment, it's not a guarantee that there's going to be success. No, these treatments are better than most treatments for psychological problems. And it's actually very hopeful. But, we're not always successful. And sometimes you have to do a second round or try something a little bit different. But the treatment for PTSD, I think, is just not done nearly enough, because it's difficult. It is difficult. The first thing people say is, doctor, you're asking me to relive the worst events of my life? And I say, yeah, I'm sorry, but that's the best treatments.
Yeah, and I would suspect that it would be very difficult as well to pursue that treatment or therapy or support when you're still caregiving.
Well, it's very interesting, because some people have said in the past that, well, maybe, you shouldn't treat PTSD during when there's going to be more trauma. That's not true. The best evidence now is that what you can do is that it may be even preventive of future traumatic events becoming PTSD. The evidence isn't completely clear, but it's clear that there's no danger in treating PTSD when somebody is having ongoing, if they want to, of course. This is always has to be that people want to have that treatment. But it's important to talk to a therapist who is experienced in doing these difficult exposure-based treatments. They are hard. They're hard on the client and they're hard on the therapist. And sometimes therapists, even though they know how to do it, they don't do it because it's hard on them.
Yes, absolutely. And maybe a follow-up to that question around severity. We had a question come in around, does PTSD differ following an acute trauma, prolonged, or chronic trauma? So sort of along the lines of what we were just talking about. Prolonged caregiving for an aging parent or for a child with a neurodevelopmental disability. Does treatment differ then for those different, that prolonged acute, prolonged chronic, and is the recovery period different?
There's no evidence, no scientific evidence to suggest different treatments. It's amazing. I've treated some people with very long duration. The hardest things are when people have to go back and dig up something from prolonged sexual abuse from in childhood. And that's unfortunately that's not that uncommon. And that's difficult. But the evidence is that, if you have more trauma, it may be a bit harder than a single event trauma to overcome, but the treatments are very effective for those. And they're, as I say, among the best psychological treatments that there are. But you have to follow these protocols, not just talking about it in general. What I would call general psychotherapy will be helpful, but it doesn't get to that memory issue of reprogramming the memory. And that's what we're after with these exposure treatments.
No, that makes a lot of sense. Reframing, rethinking, reassessing, and experiencing those events in order to, minimize or mitigate some of that.
And oftentimes people have what I might call a cocktail party conversation about their trauma, and they can talk about it very light, on the surface. But once you go down deep into the actual memory, then it's not unusual, for example, for my clients to be crying and to be upset. And I respect that it's very difficult, but that means that we're getting at the link between the event and the emotions, and that's more likely to be effective. And avoidance is really, really important. In some of these therapies, they actually prescribe, for instance, in prolonged therapy, you actually prescribed a homework where you go and you expose yourself to those things. In written exposure, the protocol doesn't call for that, but they do call for not avoiding the thoughts and memories.
Mm-hmm. We have a question here. This person has shared, I'm a caregiver to my husband with dementia, on top of caring for our 3 children who are young adults with autism, intellectual disability, and epilepsy. As far as PTSD goes, what do I need to watch for in myself? So what are some of those key, I know we covered it at the top of the presentation, but as a reminder for folks, because you shared so much wonderful information.
I'm sorry.
No, yes. It's great. What are some of those key things that people should be aware of and maybe tweak in their minds that this might be something I need to seek support or advice on?
Okay. So, with that type of burden, I would say it might be a good idea, if you can, to have sort of a checkup with a therapist just to talk about it. There's also, for PTSD, it's the reliving of past experience as if they were there, So I can recall the memory of my daughter when she went into seizures when we were in Banff on a trail, and we had to we finally got her to a restaurant, in Banff, and there was a doctor there, and we got some Ativan, which is the treatment for these seizures, and then she was in the ambulance and so on. But I know that that's past. I never experienced that as current. But when you have PTSD, that becomes the difference between what's past and what's happening now. It becomes mixed up, and so it may have flashbacks, may have a lot of feelings of that this is what's happening now isn't real, that's what's real, or that there may be other symptoms of the that we mentioned in the PCL5. So it's fundamentally that I can't separate. It's not just a difficult memory, it's a memory that comes in and takes over my life.
Right. Right.
So
it's that reoccurrence or reliving something that was difficult or traumatic, but it's impacting how you function today.
That's exactly correct. Mm-hmm. You say it better than I do, Katie.
I'm here to summarize. So if folks are in our audience are thinking about, what might this look like for me, if you're doing your day-to-day caregiving tasks and you're finding that washing those dishes, you're going back to that memory and it stops you in your tracks, or you're not wanting to go on that car ride or to that doctor's appointment or to something because it's triggering a past experience.
That's an indication. Now, PTSD can be diagnosed in this province in Ontario by a psychologist or by a physician. And the formal diagnosis is important. It could be depression, or it could be just anxiety. Those are serious problems, and they are elevated in caregivers, because of the demands. I don't think anybody who hasn't been a caregiver or hasn't been involved understands how demanding caregiving is. It's in terms of the health system, the whole health system would collapse. It's in difficulty now, but would entirely collapse without caregiving. And unpaid caregivers are the heroes of our health system, and they're just not recognized as the important contribution. But also, not only is there important contribution, but there are risks for it.
Absolutely.
And it's very rewarding to care for somebody that you love. It's something that is very rewarding, but it also is extremely demanding. And I don't think people realize, the general public and the health system doesn't realize how demanding it is. And it's a 24/7 job oftentimes, not always, but oftentimes. And it demands there's a physical demand, but there's also an incredible psychological demand.
Absolutely. And thank you for acknowledging that. We know that caregivers provide, roughly 70% of patient care across this province. And we can say they're the backbone of our healthcare system in many ways. And so that doesn't come without a cost, right? And for a lot of caregivers, they experience that physically, their mental health deteriorates. So conversations like this is really important to help them build some awareness for themselves about where to seek help, how to seek help, and where they can get started. We have a question.
Go ahead.
No, please.
Well, I just want to say that indeed there is not enough help available, and there's not enough mental health care available. There's not enough relief care available. I think these are political choices that we make as a society, and I don't think we've made the right choices.
We had a question that came in around diagnosis, and do you need a diagnosis? So as you mentioned, in this province, you need to see psychologists, psychiatry, the specific professionals in order to get this. You're not going to get it from a social worker or like a psychotherapist or someone like that. Do you need to have an official diagnosis before seeking a therapist for these types of treatments? So that exposure therapy piece.
That's a good question, and there's no entirely good answer for it. A diagnosis is simply it's a bit different than a diagnosis of COVID. You can diagnose COVID on the basis of a test that shows antibodies or presence of active pathogen. A diagnosis of PTSD it's a collection of symptoms, and it's not the same as a diagnosis of an infection, and consequently, that has to be the choice of most therapists. Will not treat without a diagnosis, but if you've done your homework and you're pretty sure you have PTSD, and there's all these instruments are available on the web for free. And I would not say that you absolutely require a diagnosis, but you have to be confident that that's what's causing the problems, because it's I sit on the fence on that.
Mm-hmm.
I mean, I wish if there were enough psychologists and psychiatrists and family doctors who are trained in this area, I'd say, oh, no, just get a diagnosis first. But it's really hard to get that service. Mm-hmm. So I sit on the fence.
Yeah, and it's not a well discussed or very common conversation in the caregiver space, right? I don't think that we talk about the impacts on caregiver mental health from anxiety, depression, those perspectives, but PTSD. In my experience in the space, and I don't know if you have a different opinion, it's not often brought forward. We think about those other mental health diagnoses, and maybe that might also be a bit of a barrier there.
Well, I don't think it's a barrier, because if you go to a therapist for treatment of depression, they'll quickly find out, if they do a proper history and such, that you have PTSD. But I do agree entirely, it's not something that we were aware of. As I mentioned, the only reason that I got into PTSD research was a parent who said, "Pat, smarten up,"
Yes.
And Donna Thompson is a very good friend, and she was working with me on another project, and she said, "Just think about what we have to go through." And once I did, and once we started doing that research, it was very evident that was the case.
Mm-hmm. Yeah. Sometimes it just takes a little nudge from those caregivers to remind us what they do every day.
Yes, I think actually a good swift kick in the pants is what us professionals often do need.
Yes, we just got a comment in the chat. Thank you, Donna. And yes, thank you, Donna. For those that aren't aware, Donna is a strong champion in the caregiver space, and we need caregivers like her to help us continue to move things forward. So thank you, Donna, for enlightening Dr. McGrath and bringing us all together today. So we have about 4 minutes or so left. Ooh. And lots of questions that have come in. I'm trying to, pinpoint those questions that are going to be most supportive to as many folks as possible. So I'm looking down at the questions rolling in on my phone here. We had a question come in. Is it possible that a recent event that's traumatizing brings past and even childhood traumas that converge to sort of create this mixture of PTSD?
Absolutely. That's very common. So somebody may have had some very serious trauma as a child. They tend to, they've been managing it fine. They're not getting a lot of symptoms. And then maybe even a smaller trauma comes along, but it brings everything back. Then the PTSD sort of explodes into their lives. And that's very common. And it's, the thing people are not crazy when they have PTSD. They're responding to it's a normal thing to have PTSD. If you have enough trauma, almost everybody will have PTSD. And, I don't think we recognize the prevalence of PTSD in people like this.
Mm-hmm. Mm-hmm. Absolutely. Absolutely. In your research, you talked about your area, I believe you mentioned, was really around parents of children who are neurodivergent or had
Yes.
neurodevelopmental issues. We've got some folks joining us today who are supporting older adults, people with dementia diagnoses or aging complications. Do you have any comments on PTSD for caregivers that are supporting people in that sort of arena?
Well, I think it's pretty much the same type of, from a psychological point of view, it doesn't matter where the trauma comes from.
Mm-hmm.
And it's ongoing. And, and the other thing is that, as I mentioned, the interference with sleep and the interference with socialization are really important, because we know that social support is a very, very important predictor of being more resilient to PTSD. So if it's important for caregivers to realize that, yes, they have huge demands, but they have to carve out small, a little bit more, not maybe a huge amount, just a little bit more, a smidgen more of time for them to have social support and also to protect their sleep. That's very difficult, and I'm not pretending to say that it's just, oh, do it, but it is, those things are really important. Self-care is so important.
It is so important, and it's often very difficult for folks in this space where they are experiencing that level of trauma that's going to cause PTSD. But despite that, even those few moments, those, and picking one thing, if sleep is that thing, which we all require, good quality sleep, that's going to make a world of difference, especially if you haven't slept for 10 years.
Yeah, well, and we're all more vulnerable when we're sleep deprived. We're all more vulnerable when we're isolated. And so it's critically important to understand that your ability to caregive is going to be degraded by not taking care of oneself.
Absolutely. We had a question around hypervigilance. So we know as caregivers, for anyone, whether it be a senior person with dementia, a person with a cognitive disability, we're often on guard and hypervigilant all of the time. Is there any interconnection there with hypervigilance and PTSD, or perhaps is that just part of caregiving?
Well, PTSD is it causes hypervigilance. Okay, so what the goal should be is not to be hypervigilant so that you're like that, but hypervigilance that you're aware of things, but you don't trigger that. It's called sympathetic arousal. You don't trigger that so high. Just vigilance is important, but not going into the hypervigilance. So one should be vigilant. That's good sense. To pretend that you shouldn't, that's crazy, but the hypervigilance does not actually see more. You're not more likely to pick up danger. You're not more likely to, if everything triggers the danger response, that's not good. And that's the problem with PTSD. Everything triggers the danger response. So you want to be able to wind that down a bit. And that stress would make PTSD worse and more likely for PTSD to emerge, but also it's a result of PTSD. It's very easy for me to say that. It's much more difficult for people to dial back that danger recognition.
Yeah, when we feel as caregivers, this is our job. Our job is to take care. Our job is to make sure there's safety and things. But I think you distinguish it nicely, where there's a difference between being vigilant and then there's that hypervigilance where it's amped up, and that added level isn't necessarily going to impact the outcome in your day-to-day. It's impacting you as an individual.
And you just won't see the real danger. If everything's dangerous, then you don't see the real danger.
Right. No, that's a very good point. So if somebody, and maybe we'll wrap up on this as our last question, if because I hear this from folks a lot around that hypervigilance, and I'm always on guard and I'm ready to go, even when I'm not. If someone starts to notice that this is something they're taking on, they're being hypervigilant, is there one tip or strategy or recommendation that you would offer them?
Well, I would encourage them to say, okay, to the story that they tell themselves, the self-talk. Okay, well, I just have to look for the real dangers, not every possibility, because anything could be a possibility,
Sure.
in any situation, not a possibility, but look for the probabilities. Something is probably, and unfortunately, sometimes we're going to miss things. But we're going to miss things if we're hypervigilant too. We're going to miss more if we're hypervigilant. The other thing is that the use of meditation or deep, slow breathing can calm down the physiology. So there's the brain in terms of the thinking, and then there's the body in terms of that sympathetic urge. It's not sympathy, it's sympathetic nervous system, where it gets you ramped up, heart rate increase, sweating increase, and jumpiness increase. And of course, the brain and the body are totally connected, but that's what we can work on, those two factors.
Great.
I would like to thank everybody for being so attentive, and I'm sorry I couldn't see all your faces, but the questions were great, and you have to be commended for all the work that you do, and you are the backbone and the muscles and the guts of our whole society is caring for other people. Thank you very much.
Thank you. Thank you, Dr. McGrath. Unfortunately, that's all the time that we have for today. I feel like we could have continued this conversation. There were a lot of wonderful comments and feedback that came through the chat box and questions for folks that are asking. The recording and the slides and any resources will be shared out to everyone who's registered to the webinar today. But I think that's all the time we have for today. And I want to thank you again, Dr. McGrath, for joining us today and providing such important information and guidance on PTSD, the effects on caregiving. And it's helpful to know more about PTSD and that it can affect caregivers and their strategies and things, supports available, should that be something that caregivers are facing. So thank you so much for your time.
Thank you.